Thank you for joining Data Elemental to Health and the Centers for Disease Control and Prevention for the second event in our series of briefings on preparing our public health data systems for the future. Today, we present Better Data, Better Analytics, Better Response, a conversation about CDC's new Center for Forecasting and Outbreak Analytics. I am Janet Hamilton, and I am the Executive Director of the Council of State and Territorial Epidemiologists, or CSTE. CSTE represents applied public health epidemiologists in state, local, tribal, and territorial health departments, and is one of the founding members of the Data Elemental to Health campaign. When the COVID-19 outbreak began, our public health system was under-resourced and unable to adequately respond to a threat of this magnitude. The pandemic highlights critical gaps in our public health data infrastructure, but we saw this coming. Before COVID-19, Data Elemental to Health came together to advocate for sustained, dedicated funding to bring our public health data infrastructure into the 21st century. At last week's briefing, we talked about CDC's Data Modernization Initiative, or DMI, a groundbreaking project that is creating a standards-based, interoperable public health data infrastructure. If, and I say if, it is appropriately resourced with sustained annual funding, DMI will ultimately ensure all public health systems can communicate and share data seamlessly with one another. DMI will better equip our public health officials to fight any emerging threat, delivering the right data at the right time. The resources needed are not insignificant, as we discussed last week, but they are real and they are realistic if we want to make data a priority. Our estimates are that we need a federal investment of at least $7.84 billion over 5 years to modernize our state and local public health infrastructure. Additional funds are needed at CDC. Plus, as you will hear more about today, the data that we collect at the state and local level plays an important role in helping to predict and respond to future outbreaks. The Center for Forecasting and Outbreak Analytics, or CFA, is a revolutionary new center that will use public health data to serve as a hub for modeling and analytics, helping to enable timely, effective decision-making to improve outbreak responses and arm officials and policymakers with the information they need to better protect their communities. The DMI and CFA go hand in hand, and we will hear more today from CFA staff and public health officials in the field on the important work the new center will undertake. Modernizing our public health data infrastructure and supporting the CFA requires robust and sustained federal investment. Data Elemental to Health is advocating for a minimum of $250 million investment in fiscal year 2023 for CDC's DMI and an additional $50 million for the CFA, and we ask for your support in those efforts. Before we begin our panel discussion, I want to remind everyone that our event is being recorded today. If you have friends and colleagues who weren't able to join us, we look forward to sharing the recording with them. And please think about your questions as our panelists make their remarks. You can submit them in the Q&A box, and we will do our best to get to as many questions as possible. After the formal program, please stick around for an informal meet and greet with a few panelists in the Zoom room. Before I hand our briefing over to our moderator, I'd like to introduce Senator Patty Murray, Chair of the Senate Health, Education, Labor, and Pensions Committee and the Labor, Health, and Human Services and Education Appropriations Subcommittee. Senator Murray's support has been integral in the funding for DMI and the establishment of the CFA, and we are honored that she is sharing these opening remarks for us today.
Hi all, I'm Senator Patty Murray, and I'm glad to be joining you for today's virtual briefing on the CDC's new Center for Forecasting and Outbreak Analytics. This pandemic has shown us time and again how important it is we invest in our public health infrastructure. Too often during this crisis, we've been caught off guard or struggled to get the data our communities needed to understand and address threats in real time to save lives. That's why I pushed to help create the Center for Forecasting and Outbreak Analytics in the American Rescue Plan, and why I hope to strengthen it with our bipartisan Prevent Pandemics Act. The center is, in fact, the first government-wide center of its kind in the United States that can both forecast disease threats and use data to mitigate their effects. It will fill a glaring gap in our national public health infrastructure by bringing together the best available data to forecast emerging health threats and ultimately help us better prepare us for public health emergencies like COVID-19. Armed with high-quality public health and disease modeling data from this center, we will be able to identify disease threats on the horizon, model the trajectories those threats might take, and perhaps most importantly, give public health experts a head start on the steps they need to take to protect communities. It will be an important research which will ultimately help save lives, and I'm really glad to be joining you as it launches today. This pandemic has been absolutely devastating for people and communities across our country. It's so important we learn from the lessons of the last 2 years, continue improving our response to COVID-19, and are better prepared for future threats, because there will be future threats. I'll be closely following the center's critical work in the months ahead, and I'm going to keep working hard in the Senate to pass the Prevent Pandemics Act and improve our pandemic preparedness with important innovations like this one.
Again, thank you to Chair Murray for those remarks. I'll now introduce our moderator, Dr. Dylan George, the Director of Operations of the CFA. Thank you all so much. Dylan?
Thank you, Janet. Good afternoon, everyone. Thank you for joining us for this call. Before we get to our amazing panelists, I'd like to share just a few comments on the Center for Forecasting and Outbreak Analytics, what we affectionately refer to as CFA. In August 2021, Rochelle Walensky recruited me and 3 fantastic colleagues to join CDC and stand up the CFA. Our small but mighty team was given a critical task. That task was to build an improved ability to forecast and model emerging health threats, as has been explained already. And since then, we have been establishing the foundation for what will be an important and impactful capability for our nation to prepare for and respond to infectious disease threats. There's 3 main pillars to what we're focusing on within CFA in these early stages, and we refer to them as predict, inform, and innovate. In Predict, CFA is building a world-class outbreak analytics team with experts in infectious disease modeling, epidemiology, and data science. And this team will develop a faster, richer evidence base to guide decision-making during emergencies. And they will establish technology architecture to do this work at speed. And importantly, they will collaborate with federal, state, and local leaders in decision support making. That'll be a critical feature on what we're doing going forward. That's Predict. Inform, CFA will build a team of expert communicators to continuously share insights from the Predict team with the federal, state, and local partners and with the public. The team will translate forecasts and analyses that support public health decision-making. And last, we aim to build capacity at the state and local level to produce and interpret these modeling and analytical results. So that's Predict, Inform, and lastly, Innovate. CFA will advance research and development priorities to improve all aspects of forecasting and outbreak analyses, from the technology to the science necessary to do this. CFA has already awarded $21 million in funding to academic institutions and another $5 million to partner federal agencies to advance modeling and forecasting methodologies. And we have within these particular efforts, we have an explicit focus on workforce development and health equity. We're going to be announcing additional investments in the coming months, and so stand by for those. So far, the CFA has demonstrated some early successes, and we are excited to build on these successes. So please do keep an eye on us. It's been amazing what we've been able to build together in just a short amount of time. And let me be clear, though, it's like we need you and we need your help to continue building this capability. So thank you for being here today and joining us. Now, to our amazing panel, you are really in for a treat today. I'm particularly excited about both our panelists today. On the panel, we have Dr. Ann Zink from Alaska and Dr. Jeff Duchen from Washington. And I'll first turn to Dr. Zink. Dr. Zink is the Chief Medical Officer in the Alaska Department of Health and Social Services. She grew up in Colorado, trained in medicine in Stanford, and then did her residency at the University of Utah. She and her team have been leading Alaska through the COVID pandemic over the past 2.5 years. And she is the upcoming president-elect for the Association of State and Territorial Health Officers. Interestingly, Anne has been a mountaineering guide. So as you can imagine, I bet she has some pretty interesting stories about some of those experiences. But more to the point that she's just an excellent communicator, and we are exceptionally lucky to have her on the panel today. So Anne, thank you for being here, and over to you.
Great. Thanks so much, Dylan. It's an honor to be here. And thank you to this team. Thank you to the Senator for that beautiful opening. Thank you to CFA. It is a true pleasure and honor to be here. I have had the responsibility and the honor of being the Chief Medical Officer for the state of Alaska throughout this pandemic, and oftentimes felt like I was swimming upstream with weights on my ankles and wrists trying to respond. And I think that we have a better way. We have things that we can do better. So I'm just going to start off and talk a little bit about what the vision is, why this is important, what it really needs to be successful from a state perspective and a local perspective, and then why now. You know, when I got here today, I checked to look at the weather. I looked at my app, saw that the weather looked actually gorgeous here in Alaska, and came on in without a big old jacket and didn't have to wear my my raincoat. The same is true with how we are thinking about CFA and how we're thinking about informatics and information to be able to prepare. When COVID came out and we first started to learn about this virus, we learned and had very little information about it. And so we had very little information that we could share with individuals as well as with policymakers. You know, many times with our governors, with our legislators, with our leaders. Well, what does this look like? How are we supposed to know how to act? What should we do with businesses? How should we be able to respond? Were all questions that I could not answer as the Chief Medical Officer. And while data continues to change, information changes, and science continues to progress, we did not have the basic tools to be able to respond to that. So just like we have a national weather forecasting tool that looks at the national weather and gets local input, thinking about how we can use those same information and informatics tools to be able to think about infectious diseases, to provide local and relevant information to local providers, local officials, and policymakers just like yourself to be able to figure out what to fund and how to move forward. During this pandemic, we had to put a National Guard personnel in our state labs to be able to enter one positive lab test into 3 different systems. We in the state of Alaska had no testing capacity. The hospital I work at has no PCR testing. We had no commercial testing in the state of in Alaska overall. And we had huge challenges being able to even see or be able to develop those cases. Procurement is incredibly challenging within the state level. And so knowing what we needed to do and when we needed to do it was incredibly important so that we could get ahead of this, the goal for being able to get procurement and information that, to be able to respond to the pandemic. And there have been huge gaps in who we see and who we don't see. There was a great quote by Mr. Grand from the WHO where he talks about that every epidemic starts locally in the community and every epidemic ends locally in the community. And just like politics, this all is local. We also need to think about the way that our health information is not only responsible and shared on a national level, but that we have syndromic surveillance and being able to understand what this looks like on a local level to be able to respond to the infectious disease challenges that we have moving forward. Janet once said something on a meeting previously that I really loved. People need to see the me inside of the we. Right now, our system is very much set up to be able to look in the past, to be able to document what has happened, but is not able to respond in the present and be able to look at forecasting and nowcasting to think about how we need to prepare for the future. And we need to be able to pivot and change that space. We need to be able to bring visibility to the invisible. We cannot just rely on those who can get testing or states that are able to advocate for large groups of testing. Again, early on in the pandemic, large commercial testing sites gave testing to those who they already had commercial relationships with. And we were clearly told that they would only give testing to those with the most number of cases, not the number of cases per capita, leaving out rural states with a complete lack of ability to see and understand what was happening in our communities, much more so than many of the more urban areas. So we need to make sure that we are able to design a system that is able to see those who are able to access care and those who are not able to access care, to have a good overall metric of what is happening in our country, as well as in our states, to be able to respond appropriately, effectively, with the right tools at the right time. We need to make sure that these tools are easy to use and easy to be actionable. Our Chief Health Information Officer often talks about needing FOMO and data. We need to make sure that people is usable and actionable, and they want to be able to check it. So just like I, checked my weather app prior to coming in, it would be great if I had my COVID app and I could see specifically what the cases look like in that region before I fly there, so that I can make a decision on my masking, or if I'm going to go there from someone who's immunocompromised, and that we can then have a better idea of how to respond both as an individual as well as local, state, territorial, and tribal entities to be able to respond. Thinking about where we need to go from here, I hope that we see this as a never again moment. I truly believe that we are less prepared for another pandemic now than we were at the beginning. Much of our response has been built on the heart, the sweat, the blood, and the tears of public health workers who are leaving in droves. I, as an emergency medicine physician, initially came to be okay with and understanding that bad things sometimes happen to good people, that accidents happen, that car accidents happen, that cancers happen. But what I have never been able to be okay with is the fact that we have systems that you design, that I design, and that we collectively design, that continue to fail patients. What we have seen consistently in this pandemic is that we have information systems that have failed the public, that have failed our policy leaders, that have failed our general understanding and be able to respond, and ultimately have undermined the trust in science. They have undermined the trust in our systems. They have undermined our trust in government. I have oftentimes said that throughout this pandemic, I have learned that we have had three major I's that we have had and that we need to respond to. The first is the lack of informatics, the lack of being able to connect systems together to understand the response. Again, if I'm not able to enter one test into a system that doesn't require a person to enter into three different systems, or right now with my sequencing data, I have no way to link that sequencing data easily to knowing if someone was symptomatic, if they were vaccinated, if they had recently traveled, again, leaving me blind into understanding the depth and greatness of that data. We have a lot of data, we just don't have good ways to connect it. The second I is information. We may have a lot of data, but if we do not have that in a way that is easily communicated to the public, and if we leave them with gaps of information, again, if they cannot see the me inside the we of the data, then they are left trying to make these decisions very much on their own. Information needs to be understood in a similar way that we understand infections. Certain information travels more easily than others. Certain people are more resistant to certain information than others. And I think we need to spend similar amounts of time understanding both the informatics as well as the way that information is shared. And the third lesson of this pandemic has been inequities. The gaps in the systems have created gigantic chasms that have completely enveloped certain populations. We have left certain populations unable to be seen and unable to be responded to during this health challenge and future health challenges. In this gap in informatics, information, and these inequities has eroded the basic trust that we have come to determine and have come to rely on in this country. Without that trust, these tools are useless. And so by being able to have accurate, reliable information, and that's why I very much commend CFA's commitment to prediction, information, and informatics, to be able to reestablish that trust within our systems and empower individuals to make the best decisions they can for their health, policymakers to make the best decisions that they can for the people that they serve. This is not a technology challenge. This is a policy and a will challenge. And I hope that we are able to take this as a never again moment. I hope that we are able to look back on this past few years and learn from our mistakes and our lessons learned but more than anything, give honor to the over almost 1 million lives that we have lost during this pandemic, as well as the tremendous healthcare workforce and public health workforce that has served tirelessly for the past few years, and not turn to them again and ask them to work in such a broken system. I hope that with partnership, we are able to build a system through CFA and through additional work to be able to make systems work for people instead of people just working for systems. So I'm looking forward to future conversations, and I really appreciate the honor and opportunity to be here, and I will hand it back over to Dylan.
I told you it was going to be a good panel. Yeah. Next, we have Dr. Jeff Duchen. Dr. Duchen is the health officer and epidemiologist in Seattle and King County in the state of Washington. He is a professor of medicine and public health at the University of Washington. He's active in several different national organizations, including serving as a member of the CDC's Advisory Committee on Immunization Practices, the National Vaccine Advisory Committee, and the National Academy of Medicine's Standing Committee on Emerging Infectious Diseases in the 21st Century. Jeff received his medical degree from Rutgers. He's a former EIS officer from the CDC. And for the past 2 years, he has worked primarily focusing on the COVID-19 outbreak response. We have all benefited from his insightful commentary on social media. Not only is Jeff an exceptional communicator, he also sends out these really amazing photos of his bike rides. And I personally find them very calming and very inspiring as well. But Jeff, thank you for being here. Over to you.
Well, thank you, Dylan. Thank you for the invitation. Thank you all for the opportunity to be with you this afternoon. And thank you, Annie, for that amazing talk that you just gave. This is going to be hard to follow, but I'll offer some of my own perspectives on the importance and place of something like CFA in our national public health system. You know, modeling is incredibly valuable to local public health professionals, to policymakers at the local level, and others to help us understand how infectious diseases spread and the policies that we can use to best control them. And this modeling is not new to public health, but it has not been adequately or routinely utilized by state and local public health agencies and decision makers. These models can simulate the impact of various interventions or public health strategies and provide predictions of how interventions might affect population health. For example, modeling can help us understand the severity of a new disease like COVID-19, including how rapidly it spreads, potential modes of transmission, and corresponding control strategies. So this modeling, or this type of modeling, helps us incorporate and make sense of large amounts of data to identify key gaps in the evidence base on which decisions can be made. And these evidence-based gaps that need to be addressed and answered in order to help us in public health and our policymakers think through and answer complex questions about disease transmission and control options under circumstances of great uncertainty. So in that context, some of you may know that our community had the first recognized confirmed case and the first outbreak of COVID-19 in the US. At the time, we had no clear idea of what to expect to unfold over what time frame or a playbook for how to respond. We were aware of potential community mitigation measures in the context of pandemic influenza preparedness, but no such large-scale measures had been applied in the US for over 100 years. Well, we were fortunate to have a number of world-class academic modeling groups in our county, including Trevor Bedford's team at the Fred Hutchinson Cancer Research Center and Daniel Klein's team at the Institute for Disease Modeling and the University of Washington's Institute for Health Metrics and Evaluation. And these modelers voluntarily provided valuable assistance and consultation to us without compensation through much of the pandemic. Working with our public health department is not part of their usual mission, And they did this work, which entailed significant resource investment on their part through a sense of civic responsibility and with the support of their organizational leadership. So we were very fortunate to have had local modeling experts and their resources available to us that most public health agencies do not have. But now these colleagues have understandably gone back to their usual lines of business and their priorities, which do not include ongoing support for local public health. To make effective use of modeling within our organizations at the state and local level at public health, it's necessary to have an appropriately trained and skilled workforce in our departments that understand modeling methods and can critique key assumptions and limitations. This is essential to ensure close collaboration and optimal communication between modelers and public health epidemiologists that's necessary to create the most useful and informative models. And we heard about this in the context of predict, inform, and innovate. And this is the inform and communication and understanding how models work and what their limits are incredibly important to us at the local level. So examples of key questions modeling can help us address in the future include continuing to understand the extent of disease transmission as our traditional surveillance reporting systems are less utilized, and defining the risk of encountering a case of COVID-19 at a gathering in your community, for example. Defining optimal immunization policies and disease mitigation strategies in the context of evolving SARS-CoV-2 variants and the level of population immunity from vaccination and prior infection as it changes with time. And the projected impact on healthcare system functioning of COVID-19 surges superimposed on seasonal respiratory infections like influenza, and meeting the demands that are pressing our healthcare system due to a significant backlog in care of non-COVID-19 conditions, and the health and economic impacts of long COVID. I think it's a very important and overdue step to establish high-quality predictive modeling capacity through a national center like the CFA in collaboration with academic institutions and public health programs. Modeling helps us incorporate and make sense of large amounts of data and identify key gaps in evidence on which decisions are made. And in turn, it helps our policymakers think through and answer complex questions about disease transmission and control. Another critical role for the center is to help policymakers interpret modeling results, their limitations, and applicability to real-world situations. A few other examples of key questions modeling can help us address are the relative importance of disease mitigation and immunization strategies in the context of evolving SARS-CoV-2 variants as population immunity from vaccination and prior infection changes, and the impact on the healthcare system, as I previously mentioned. Going forward, we in local public health need a more robust and sustainable relationship with modeling centers like CFA and academic modeling groups to help inform our work. We also need a skilled workforce in our state and local public health departments that understands modeling methods to ensure we can create the most useful and informative models. And finally, models are only as good as the quality and variety of the data that inform them. It's important that this activity be seen in the context of the National Data Modernization Initiative that we heard about and that is underway. We desperately need a more robust, coordinated approach with engagement at the national, state, and local public health levels to improve public health data systems and data system architecture and identify and prioritize the goals of this critical activity, including increasing the quality and quantity of data for public health modeling and ensuring access to data at the state and local levels. So with that, I conclude my prepared remarks and I look forward to a discussion with you.
Thanks both of you. That was amazingly great. We're in for a really great opportunity to chat on a handful of these topics. We will have an opportunity for questions from the audience if you'd like. If you'd like to ask a question, please submit them in the Q&A box in Zoom. Again, if you'd like to ask a question to either Anne, Jeff, or me, submit in the Q&A box. To start off the discussion, though, I'd like to ask just a few questions to get things going. And this is a question for both of you, but let's start with Anne in response right out of the gate. Several people have talked about public health. For those of us that have been trained in public health, it's largely kind of a retrospective activity of looking at, and some people have even described it as data archaeologists or public health archaeologists looking back through time to understand what the risk factors are to help protect people. Outbreak analytics, disease modeling, and forecasting are new, and Jeff, you just talked a bit about this, but how do these approaches differ from traditional public health surveillance and epidemiology? First, over to you, Anne.
Yeah, no, thanks so much for the question, Dylan. And I think that over time, healthcare and public health have become more separated. My role as an emergency medicine physician is, someone comes in with chest pain, I have limited resources and tools, and I try to stabilize them the best that I possibly can. Public health tends to look back on that data and say, what causes heart attacks? What causes, people to die from infectious diseases? And what are the steps that we can do to prevent them? And I think you really saw the clash between and the need to inform and to build public health and healthcare together during this pandemic. So when I was meeting with my governor and he's like, how many beds do I need? I need to know this tomorrow. How many people are going to die? How much, money is this going to cost us? What does this mean long term? Before we even have a case, the answer is oftentimes, I don't know. But the real challenge was that the way that the public health system has been set up in the past has been, for example, our death certificates take almost 18 months to fully come in and for us to review, to be able to then look back in hindsight and to say, these are the leading causes of death. Well, when you're in the middle of a pandemic and you have the Omicron variant versus the Delta variant, you're seeing very different things that require very different resources and have huge impacts on our safety, our security, our economy, our kids in schools, and to be able to give people real-time decisions. And so I think we very much need to blend healthcare and public health to be able to respond to kind of that now, understand what's happening as best as we can and translate that as accurately as possible to the public. Be able to look at short-term kind of forecasting or nowcasting. What do we know in the next week or two? And then better understand what interventions and what things can we do kind of for the long term in the future, as well as looking back to be able to understand where we're at. And I think that that's the real hope with CFA, from my understanding, is to be able to take the data and tools and the brilliant minds like Jeff and so many others who have been working so hard at understanding this information and make it applicable to you all as legislators, to me as a public health official, and then also to the mom on the street who's trying to make the best decision they can for sending their kid to school, but also caring for, an elderly grandmother in their house. This is a hope to be able to use this information to be able to be more on time, more relevant to all Americans as we find better ways to respond to other health challenges.
Yeah, exactly. I think qualitatively, from my perspective as well, the fundamental difference between this and like some chronic diseases in public health is the exponential growth that could happen in an outbreak scenario, which puts it into a very different setting and trying to have to look forward instead of backwards. But Jeff, continue on. You had mentioned some of the differences in the two kind of the traditional approaches and some of the things that we're talking about in outbreak analytics in your opening comments. Continue on. What other things would you add on there?
So, sorry, Dylan, just to clarify, following up on the same question?
Yeah, exactly.
Yeah, no, I mean, I think the key value here in a center like this, in an activity like this, is helping us grapple with uncertainty. I mean, we know we're going to be faced with additional new diseases emerging and new health threats and new combination of health threats. And you can look at cascading impacts of infectious diseases and things like disasters, climate disasters. We've had deadly heat events, floods, and other weather-related disasters, smoke and fire, all of which have impacts on our healthcare system and interrelate with other ongoing health problems. And so even during COVID, we had multiple cascading impacts locally due to other climate-related emergencies. And so we've got these situations now that are new, they're unfamiliar to us. We have emerging diseases where we may not understand how they spread, how rapidly they spread, the severity of illness that they cause. And being able to rapidly acquire the type of data that are necessary to understand to the greatest extent possible what's happening, and then take that next step and predict forward what we need to do about it. This is really the unique value of this type of activity. Traditional epidemiology, as you've heard, we are very good at characterizing what's happening. We count cases. It's slow, it's methodical, but it produces a clear picture in the rearview mirror of what just happened to us. What we need now is to adapt to our changing reality and the actual potential that we have to be more forward-thinking and proactive, and allowing us to formulate the best responses possible to the many new types of health threats that we're inevitably going to be facing in the coming years, including infectious diseases and others.
Super. And Jeff, as a follow-on question, can you talk a little bit more about what it was like? You had mentioned this in your opening comments, but what was it like working with the academic modelers and the forecasters and supporting you in the early stages and then subsequently? Can you give us a little bit more flavor on that?
Yeah, sure. As I said, we were so fortunate. Early on, Trevor Bedford and his group at the Fred Hutchinson Cancer Research Center helped us understand the potential extent of unrecognized spread of COVID-19 in our community. We had 1 or 2 cases that popped up over different timeframes, and they were able to analyze using sequencing data from the virus how many cases were actually out there that were not reported to us because you may remember the surveillance case definition at that time was very restrictive, and we could only test the sickest people who had a travel history, for example. So understanding what was beneath the tip of the iceberg here, the true extent of community spread helped us understand what we might expect in the coming weeks, the implications for the timing and extent of the epidemic growth. And this really helped us inform our decisions about implementing large-scale community mitigation measures, such as stay-at-home orders, closures of non-essential businesses and schools, and prohibitions on large gatherings. And these were, as you can imagine, not trivial decisions for our elected leaders. In addition, we had colleagues at the Institute for Disease Modeling to help us understand, for example, whether transmission and outbreak size over the course of the epidemic was growing, plateauing, or declining, how rapidly it was changing, and the value of testing and contact tracing in limiting community spread, the impact of in-school transmission on community spread, and the relative value of different testing strategies and school schedules, such as hybrid scheduling, for students and staff on returning to in-person learning. So, some of these mitigation measures, which hadn't been used, we just wouldn't been able to evaluate without the assistance of these modelers what their actual impact was of the different potential strategies, the various combinations of strategies, like stay-at-home policy and masking. This modeling provided information that helped us understand the true prevalence of infections and disease burden in the community, given what we know is incomplete case reporting. And again, helped us know whether the epidemic was growing, plateauing, or decreasing. And then finally, our colleagues at the Institute for Health Metrics and Evaluation modeled the impact of our local vaccine verification policy, or Vax Passport, where we required proof of vaccination for participation in certain activities such as indoor dining, indoor recreation, entertainment, group gatherings in public spaces. We were considering implementing this policy, and we needed to know what the impact was going to be on COVID-19 cases, hospitalizations, and deaths to know whether it was worth the tremendous effort. And you all know how controversial these policies are. So this analysis that they did was instrumental in our decision to go forward with this mandate. And then most recently, our governor used the results of modeling Washington state hospitalization rates in deciding to lift our statewide indoor mask mandate. So those are some examples of how we benefited from having local modeling experts engaging with our public health system during the recent pandemic.
Anne, I'd love to pivot to you though too. It's like, could you describe how you interacted with using different sorts of modeling analytics? Because it's clear from Jeff's comments that it was useful in a range of different options to understand what the options were, what the costs would be and potentially what the impact would be on the trajectory of the pandemic going forward. How were you able to access some of this information, or what challenges did you have in accessing it?
Yeah, no, I appreciate that question. And in fact, I would say that we weren't able to access it in many ways. And that's where I really think that as we move forward with thinking about how we want to do this as a national strategy, we need to think about who is left out and who is included. You know, when we would meet with modelers, they would say, do not use these in Alaska. They do not work there. You have too big of a space and too few of a people. And I'm like, well, what am I supposed to use then? Like, I still got to make decisions. And what do you suggest? And they're like, good luck. I don't know what to tell you in that space. I mean, this continues today. I mean, even currently the CDC community guidance, you know, in Alaska, we are bigger than Texas, Montana, and California combined, with more coastline than the East and West Coast. And they have divided us into 4 separate health areas that have, you know, communities that are 700 miles apart, but they put them in the same risk zone, with communities that like never interact with each other and don't have the same hospitals. It does not work for our community. We need to make sure that this is two-way communication between what's happening locally. Not every model is going to work for every single scenario. Like, I'm not saying like every model has got to work for Alaska, and there are models that just are not going to work. You know, you get one family with, I mean, currently we have a situation today where there was one group of people who all got sick and ended up at a hospital, and it took the CDC community map from a green to a red because of the number of hospitalizations in that one family. So you get a lot more noise when you have a lot more smaller groups and communities. And that's going to be the nature of just modeling and with data. And that's okay. And that's understandable. But I think we need to recognize that risk, but we also need to make sure that we're getting local input. So, you know, during the Omicron wave, Maine was 60,000 cases behind in entering their case data. And that resulted in them getting less therapeutics because they were entering less data. But it was like literally they didn't have the people to enter the data into the systems fast enough. And if, you know, big modeling can be able to get local input to say, this is going to be out of sync because this feed is down, or we know that we're behind in this space, we can help to make those models much more accurate to be able to provide two-way information. And the same thing happens with weather right now, being able to give local, well, there was a big forest fire went through here, so things are going to change. I think that this needs to not be a unidirectional information, but this needs to be a bi-directional conversation with local, state, territorial areas and these big models to say what works, what doesn't, what information and tools do you need, and what are you seeing on the ground, and how does that reflect, and what ways can we change and help to predict our modeling to be able to support forward. And so I think that that's going to be key, and why I am excited to be a part of these conversations, and why I think that the structure of the way this is being set up makes a lot of sense, instead of it just going to an academic site to do modeling for big urban areas.
Real quick, I wanted to pull in Janet into this conversation as well. I know that she's had some experiences along these lines as well, but over to you, Janet.
Yeah, thanks so much, Dylan, and amazing comments from both Jeff and Ann. As always, I learn something from them every time. I just was going to reflect too on how we communicate better data and information to the public that inform space. So, you know, CDC just came out yesterday with some great data on the estimated number of cases that we're not identifying. So we're now in a space where, you know, for every case, there's probably 4 that we haven't found. But I don't know that we're presenting that in a way that's digestible and is also predicting forward for people what has happened in their own communities. So again, that's sort of that we're showing people the rear view mirror, but why can't we also be showing people at the same time, based on what we know, this is what the actual experience is, and this is where we're going. And, you know, that's the #1 question that I often get from my membership, the state epidemiologists around the country, is them posing the question of, everyone keeps asking me what's happening next. How can we get in front of this? And we can't answer that question now. And I think that's where CFA has a real opportunity to help not only us in public health answer that question, but for people themselves to look at data in a way that's more meaningful, that allows them to say, this is what's happening around me, and this is probably what's going to happen in the next week and 2 weeks.
Super. Thanks, Janet. I'd love for each of you and Janet as well, if you're interested, to take a moment and say, it's like, be very specific about, it's like, how could this kind of capability be very useful for members of Congress? I mean, you've done a beautiful job of describing it from a health officer's or a state EPI's position, or a locality or a governor's position. Could you talk a little bit about how members of Congress could potentially be using this information more effectively to help in navigate going forward? Start with you, Anne.
Great. Yeah. I oftentimes say that to have any meaningful change in healthcare, you need to involve providers, patients, policymakers, the press, and the public. And policymakers are critical to being able to do this. And in fact, we had incredibly blunt tools that we use to respond to this pandemic instead of very surgical and fine tools. And CFA ideally would give us fine tools to be able to respond. So you know that if you're going to help give us money for ELT testing for schools, how that's going to be most effective, like where we're going to use that and how we're going to do that. And is that antigen testing? Is that PCR testing? Wastewater, 80% of my communities are on septic systems. Wastewater is just not going to work. I have 32 communities with no running water or sewer to start with. So it's like a non-starter for thinking about wastewater testing. So to make sure that every dollar that comes from Congress is most effectively spent on anything from health to preventative health, to public health, to security is spent as effectively and as efficiently as possible, we need to have better information. I also think that this is going to make a big difference for our security as a nation, as well as for policymakers to be able to communicate, just as Janet said, much better to the public that they serve over the health challenges that they have. And just like I started off by saying, every epidemic starts in a community and ends in a community, just like all politics is local. Being able to provide you all with information that is relevant to the communities that you serve is going to help you better understand these health challenges for your communities and think about how you, as a part of a bigger nation, serve your community as well as the nation as a whole. So I think it will be critical to you all as policymakers.
Over to you, Jeff. Same question.
Well, Annie gave a very comprehensive answer. I think that this type of information, will help members of Congress understand the vulnerabilities of their constituents, what their populations are susceptible to, and can help understand what types of preparations are needed to protect populations from different types of threats, and can help them understand the impacts, both the health impacts and the economic impacts of communicable disease outbreaks in combination with other types of threats. So from my perspective, and of course, personally, you will also benefit, as will any other individual, from knowing, what your risk is in the community based on the types of things that you do, the level of disease, the status of your healthcare system, and so on. The other thing that I think is really valuable is that modeling can help us grapple with this issue of uncertainty. When we're looking at new diseases, emerging threats, and combinations of things that haven't happened before, there's a great deal of uncertainty. And unfortunately, right now, the way our media landscape works, lots of people who maybe aren't really the most knowledgeable can express opinions with a great amount of certainty that people then believe, and that influence the behaviors of the public, and sometimes in very counterproductive ways. And I'm not saying modeling is a cure-all for disinformation, but modeling can help us understand the strength, the level of confidence that we have in our policies and our conclusions, and we need to communicate that uncertainty when we talk to the public about, what we're doing to control the disease, or what we know and what we don't know. Modeling can really help us, I say, identify the gaps in knowledge, fill those gaps, and then tell us how certain we are with the conclusions that we've arrived at, and over time, ideally become more certain, decrease the level of uncertainty as information becomes better and more accessible.
Janet, over to you.
Yeah, I'll just quickly say, in addition to all those incredibly wise comments, that it's really hard in a space that's resource constrained to know what's the right investment, and that's always the situation that Congress is in. So this is one of the best tools for being able to say, this is the right investment and this is the right thing to do. And all we can do is use the best information that we have when we have it. But, we all want that crystal ball. So how do we do our best job to put it in our hands? And I think this is it.
Great. Last question for all of you, though, too. It's like, I'd love to get your perspective on, it's like, if you had a magic wand What would be the thing that you would change to make monitoring, infectious diseases or the health of a community more effective, is particularly for a health emergency? Start with you, Jeff.
Okay, so if I could only choose one thing, I guess I would pick a more well-integrated and comprehensive national healthcare system integrated with our public health system, where we could rapidly ascertain, well, first of all, where everyone could have access to care that they need, that we wouldn't have people not being able to access care, either whether it be testing, treatment, or any other type of care that they need, but also have the data that accompany these clinical encounters in a standardized way, uniform across the country, reliably collected, that we can rapidly collate, organize, and interpret and use to understand what's happening in our communities, both during emergencies and between emergencies. This would be just an incredibly valuable thing from the public health perspective.
Anne?
Yeah, it's a hard question with just one. And I guess I would say, I would hope that we would put the same trust and investment in public health and healthcare data that we do in our money. We protect our money. We don't want it to go away. We don't want people to steal it, but I can take an ATM card and go to another country and they can do a conversion and give it to me and it comes safely out. And I can have one bank account talk to the other, but I cannot have that 8 different things about a positive COVID test that my nurses have to enter in the emergency department cross over to my public health lab for me to see if they're symptomatic or not. I think that this is, again, not an IT technology. This is a policy. And I think our data is more secure. I think patients' information is more secure, and we have more tools and resources if we were to give it the same respect that we give other things that are critical to our life, such as our financial. And we've got the tools, we have the resources, we just need policy to be able to invest in the connection between those systems so that the systems can be able to see between each other to understand the fuller picture of what's happening.
Super. So we are about at time. So unfortunately, we're going to have to stop. I told you we were in for a treat with both Anne and Jeff on today's panel, and they did not disappoint. So it was, thank you very much for both of you for being with us here today. Thank you for the audience for joining us today. As I mentioned at the top, we need your help to actually continue this going forward. We need you to participate in this, and thank you very much for being actively engaged in these issues. We appreciate your interest and your efforts in how you've been moving forward these capabilities on yourself. But back to you, Janet.
Yeah, gosh, thank you, Dylan. Thank you both to Jeff and Anne too. And I just want to close this out by really saying, I mean, during this briefing series, you've heard from our speakers on what is truly needed to make public health data modernization and forecasting and outbreak analytics a reality. And we are calling on Congress to consider these needs by providing a minimum investment of $250 million for the Data Modernization Initiative in fiscal year 2023 and $50 million dedicated specifically for the Center for Forecasting and Outbreak Analytics. And this needs to be sustainable and reliable annual investments thereafter. More than 100 organizations support this request, and we have transmitted a sign-on letter to the Appropriations Committee demonstrating that support. If you are joining us from Capitol Hill, we respectfully ask for your support during fiscal year 2023 appropriations process. Thank you again for joining us today. And if you can, we encourage you to please stick around for our informal dialogue. Come to the table with a few questions of our speakers. And while we can't be together in person, we are looking forward to replicating a face-to-face conversation the best we can. So if you do want to stay, here are the instructions. Remain online, number 1. Number 2, you will individually get a request to participate as a panelist. And so there's going to be an invite that comes to you through Zoom that says, do you want to participate as a panelist? And when that pops up on your Zoom screen, don't be intimidated, become a panelist and join the discussion. And we look forward to seeing you in our discussion room.